Hi, my name is Christine Reichert. I attend Indiana State University in the Doctorate in Athletic Training program. And today I'm going to be talking about integrating the lower extremity and the spine evaluation to make a complete and thorough, comprehensive lower extremity evaluation for an injury. So my current process as a reflection really follows HOPS, History, Observation, Palpation, Special Tests, something that everyone learns in undergraduate athletic training courses. I never really understood where muscle testing and range of motion fell in with that, so I added my own little segment there, and this is basically going to be the order that I go in each time. I view my process as finding clues, so a little bit like Blue's Clues down there in the corner. I think that each and every step will lead you to where you need to go and what you need to look at. And so it's a little bit like a treasure hunt. It's a little bit like a puzzle. So if you find all the pieces, you can get a good diagnosis. But all the pieces are definitely important. And let's just say I might be missing a few pieces after my reflection. So first let's talk about history. I always talk about patient background first, who they are, what team they're on, and their name. Then I go into injury background, and by this I mean looking at that extremity and looking at any injuries that happen up or down the kinetic chain, and as well as anything that happened to that particular segment of the body. And of course I go into who, what, when, where, why, the 5 W's. So who was it, or who was involved in it, what happened, when did it happen, where did it happen, and why did it happen? Of course you're not always going to get the why. But sometimes there's things that can contribute to it, like not wearing your pads or your shoe wasn't tied. When I look at injury background, I look at the kinetic chain, and I gotta say that's not very thorough. When it comes to an ankle injury, I only look at the ankle. Knee, I look at the hip and the knee. The hip, I'll look at the lower back and the knee. And the lower back, I'll look at the hip. Besides, of course, those specific segments. So, not the most thorough, but we'll get into that a little later. Observation, looking again at bony deformity, bruising, swelling, redness, compared bilaterally, can give a lot of clues into what's going on and what structure is just not working the way it should, for lack of a better term. Palpations, looking at bony structures, muscles, ligaments, superior and inferior. So looking at what lies above and below that area. So for instance, if I'm looking at the injured area, if an athlete complains of pain on her lateral malleolus, I'm going to be feeling up that fibula. Medial and lateral, looking at what is on either side of it that can contribute to it, and then feeling for heat. I next go into my made-up fourth component of HOPS. When I'm looking at range of motion and manual muscle testing, I always go with passive range of motion first, test ligamentous structure, and then I go into active range of motion. And after that, I usually ask them which would hurt more. So that, of course, can give clues on whether it is a ligamentous injury or a muscular injury. And then I test strength with active resistive range of motion. So for the ankle, I usually just test the muscles or passive range of motion of specific ankle structures. Knee, I look at the knee and the hip. The hip, I do look at the lower back, hip, and knee. And the lower back, I look at the hip and the knee. So again, not the most thorough of the kinetic chain, which we will, again, talk about in a minute. And then there's special tests. Region specific, so what is happening at that specific joint or that specific area. I may sometimes test up and down the kinetic chain, especially if I'm not getting the results that I want. So if I'm not finding any positive knee special tests, I will test the hip. And I almost always look at hip alignment. Now when I say almost always, I never look at it for the ankle. It's just not something I never felt was necessary. But I do look at when it was lower back, when it's hip, and when it's knee. I do check their hip alignment. So when I'm reflecting about this, what exactly am I missing? I think the first thing that goes is kinetic chain for the ankle. For an ankle injury, I don't look up the kinetic chain. I think that's extremely important, and that's a big gap. Second, SI joint. Yes, I check for hip alignment, but I don't look at how it affects, and I don't use it for my treatment. So there's definitely a gap there. 3, core. We always hear in every class we ever attend before we can get certified is the importance of the core. And we tell our athletes, tighten your core. But why am I not assessing that in my evaluations? And 4, patient-rated outcome tools. This has been drilled into my head all semester and all summer, and I'm finally buying into it. And I've used it as a assignment, but I'm just not quick to use it. And I think that's partly just getting used to it, but it's definitely a gap I need to fill. So I decided to pick 4 articles that really helped me understand, why I'm missing them and why it's important and how I can perhaps fill that gap. So the first one talks about lower extremity kinematic and kinetic differences in runners with high and low arches. I think this starts with looking at the kinetic chain. So for instance, high arches, you've got more foot and ankle injuries due to the higher loading rates of high arches. You have less surface area to absorb the shock. So you're going to get those bony fractures and you're going to get those foot and ankle injuries. Lower arches, you have more knee injuries due to the increased Q angle because, of course, when you look up the kinetic chain, you have to realize how the ankle affects the knee, which affects the hip. So these are all things that need to be taken into consideration. The second article talks specifically as a case report about SI joint dysfunction and Achilles tendonitis. Now, this is an older study, however, I really do think it benefits not only to remind me as why it's important to look at the kinetic chain, but also to help me understand how to go about not only evaluating but treating. So it's looking at the kinetic chain of the lower extremity, and specifically in this article it talked about posterior tilt, how it causes hamstring tightness and tricep serrae muscles, decreased dorsiflexion, which increases the load and pull on the Achilles, which can then lead to overuse and inflammation. So you can treat that Achilles all you want, but until you fix the problem, all you're doing is slapping a band-aid on it. I think this is an article that is an important reminder of the importance of the kinetic chain. Third is looking at core stability measures for risk factors. Yes, this is not exactly evaluation, but again, it serves as a really good starting point to remind me that the hip muscle and the core musculature really do affect injuries. So for instance, females have decreased hip abduction external rotation, which decreased quadratus lumborum endurance. All of those will lead to injury, and those are the things that we need to look at. So if I have an ankle injury or I have a knee injury and it's not working the way it should, or you're noticing that it's a recurrent issue, it's time to look at something else. Look at the hip. Look at the QL. In general, hip external rotation was the highest predictor of injury. Another thing that I found really, really interesting. Something I can incorporate into my evaluation by looking at their hip external rotation and seeing how that is affecting, if that's causing an issue. And last, hip strength is more of a predictor of injury than trunk endurance. So if they don't have the strength to absorb the shock or to counteract the shock or the force, they're not going to be able to really recover from injury as well. And so this is an important thing to take into consideration as well. And finally, I looked up an it's original article of the lower extremity functional scale, which is a patient-rated outcome tool that is used to understand the effects of a lower extremity injury on activities of daily living. It's super easy to score. It's out of 80. It's only 5. You've got 0 to 4, 0 being no extreme difficulty or unable to perform the activity, and 4 being no difficulty. So it's super easy to score. It's really quick to administer. I used it on one of my patients once, and it took no time at all. 4, it's super beneficial in monitoring change and setting goals. So if you notice that they have 60 one day and the next day they have 63, that can help to raise morale. So what gaps do these fill? History. Looking at patient-rated outcome measures is a huge portion of this, and I think especially if it's a follow-up evaluation. Getting rid of that chart and looking at all of them, hip, knee, ankle, and core. So next time I have an ankle injury, I'll make sure to assess the hip. Observation, I'm going to keep the same. I think it's pretty hard to mess up observation. Same with palpation. Range of motion manual muscle testing, it goes very well with history. So looking at the knee, hip, ankle, core, and the SI joint. And looking at how those affected, especially if you're not getting the results that you want or the results that are telling you anything. So you're missing those clues. And special tests, looking at the SI joint and making sure to look up the kinetic chain. So for an ankle injury, if you're not understanding why you're not getting any positive tests, try looking up to knee and hip. And of course, outcome tools. A very good tool to definitely start incorporating, especially with its ease. There's really no excuse. So now as my revised process stands, history, observation, palpation, M for range of motion manual muscle testing, S for special tests, and O for outcomes. This is a way that I can really close the gap and make a better evaluation.